Assalamu alaikum. Today we are going to talk about a very common condition of the liver. Just have a look at this photograph and what can you think about which disease process can result in this kind of a condition a patient is suffering from. Just for a moment think about it. If you look at this picture, what we can see is a large hole in the anterior wall right in the epigastrium showing white slough, and there is an area through which you can see the inside of the abdomen. So keep this in mind, and we can see that on the sides here these are the marks of a sticking tape, which tells us that there would have been a large dressing over here, and these black margins tell us that there has been some pressure over them, which has resulted into blackening of this area. So surgically calling this wound would be known as an ulcer. An ulcer is a discontinuation in the epithelium, and if you classify it according to the edges, you can see the edges are undermined, which tells us that it is a chronic inflammatory process. And then you can see that there is a lot of slough inside, and the depth is through and through. It has caused through all the walls of the and all the layers of the anterior abdominal wall. So let's see which conditions can cause this. So today we are going to talk about the cystic swellings of liver and their management. It's going to be a very brief account. It's going to be just an overview of all these things, and I would like you people to have a detailed study from your textbooks, I hope, which you study. So we'll start with cysts. What is a cyst? जब आप थर्ड ईयर में गए होंगे, अगर आपने होपफुली नॉर्मन ब्राउज या एस दास या हैमिल्टन बेले या जो भी साइंस एंड सिम्टम्स की किताब पढ़ी होगी, उसमें आपने देखा होगा कि सिस्ट क्या होती है. A cyst is a fluid-filled area which is lined by an epithelium. So what are the different cysts a liver can have? The other day while we were talking about imaging, उसमें हमने बात की थी कि cysts कैसे नज़र आती हैं, हम उनको कैसे ढूंढते हैं, सिंपल cyst क्या होती है, कॉम्प्लेक्स cyst क्या होती हैं, उनको हम अल्ट्रासाउंड पे और CT स्कैन पे वो हमें कैसे नज़र आती हैं. So let's have a look. This is a simple liver cyst. How does it develop? It is a congenital thing, and it is because of an abnormal intrahepatic bile duct in utero, in which the bile duct does not communicate with the rest of the biliary channels. So it forms into a cyst, and if you look at it, you can see the density is lesser than the rest of the hepatic tissue, and it has very well defined margins. It is smooth, the border is very well defined, and the whole of the consistency of the whole of this lesion, the cyst, is the same. So it is a simple cyst. Now it can be symptomatic depending upon the size of this lesion and also depending upon the site of this lesion. And remember one thing, it never communicates with biliary tree and has smooth margins, as I've already talked about. So do we need to do something about? Most of the times these kind of cysts do not need any kind of surgical management. Then there can be a polycystic liver disease, which usually is associated with a polycystic kidney disease in about 40% of the cases, and this is what it would look like. You can see multiple well-defined, well-demarcated cysts are present in the both lobes of the liver, and these kind of patients may present with, because of their sheer size and number, they can cause stretching of the Glisson's capsule, hence resulting in pain to the patient, and also because of the pressure on the biliary channels, it can cause jaundice to these patients. Then neoplastic liver cysts. It is definitely an acquired cyst. Both simple cyst and polycystic liver cysts are congenital diseases. They are congenitally present whereas the neoplastic liver cyst is an acquired cyst. And as we are talking about neoplastic, it can be both benign and malignant. It is commoner in female. It can attain a very large size. It is multiloculated with papillary projections. Remember, simple cysts were smooth, they had well defined boundaries, and they had similar kind of density inside them, whereas the neoplastic liver cysts are multiloculated with papillary projections, and the treatment is resection, whether it is benign or it is malignant. In both cases you need to resect these cases. Of course, we are talking about the patient in which dissection is possible. He is properly optimized. The liver remnant subsequent to the resection should be compatible with the function of the liver that has to be done. So a benign neoplastic liver cyst is known as a hepatic cyst adenoma, which contains either mucinous or bilious fluid, or a hepatic cyst adenocarcinoma, which can be malignant, which is actually malignant, and that contains blood, hemorrhagic fluid. And in a hepatic cyst adenocarcinoma, the CA 19/9 level are raised, 19-9 levels are raised. Now, what does the CA stand for? Can anybody remember from pathology? The CA stands for carbohydrate antigen, and there are multiple carbohydrate antigens which are used as tumor markers, and the most commonly used is CA125, used for ovarian malignancies. So a neoplastic liver cyst is multiloculated, has papillary projections, and requires resection surgically. And this is what a hepatic cyst adenocarcinoma can looks like on CT scan, and you can see the boundary is not smooth and it has multiple locules inside. They are multiloculations. It is multiloculated. There are projections inside, and the CA 19-9 would be raised, and when you excise that, it would tell us that it has malignancy. And you can see the invasion of capsule over here as well. Then there can be traumatic liver cyst. Now you would be wondering, why would trauma cause liver cyst? It is an acquired cyst after usually a blunt abdominal trauma. When there is blunt abdominal trauma, results in injury to the biliary duct, biliary channels. It causes leak into the existing intrahepatic hematoma and causes a mixture of bile and blood, and it usually resolves spontaneously. Now that depends upon the size of the bile duct which is injured. If the size of the bile duct injured is larger, then it is, and there is a continuous communication with this in the intrahepatic hematoma, it may be not resolving spontaneously, and it may take quite a while. So what can we do? Which investigation would you like to do for this patient? Yes, an MRCP or even an ERCP can help. We do an ERCP, we do a sphincterotomy, and we place a stent. The purpose would be to drain all hollow viscera, heal spontaneously, provided there is no distal obstruction. So if we open the sphincter of OD and we place a stent, we make sure that there is no obstruction to the biliary drainage. Even a larger sized biliary channel, if it is injured and is the cause of traumatic liver cyst, it would heal subsequently. Now then, abscesses are a common occurrence in our part of the world, and if you remember the first photograph with which we started today's lecture, that was actually a hepatic abscess which had eroded on the surface, and it has, and if you would have recalled it, you would have seen that that patient was malnourished, and that patient would presented with a wound in which the abscess cavity was directly communicating with the exterior through the involvement of whole of the abdominal wall. Now, what are the various abscesses which can happen or occur in the liver? The most common is amoebic liver abscess. As we know, it's a very common parasite, Entamoeba histolytica, और हम में से जितने लोग यहाँ हॉस्टल में रहते हैं या जिनको बाहर खाने का शौक़ है, स्पेशली ग्वालमंडी के आसपास का, हम सबको पता है कि amoebiasis क्या होता है, because all of us perhaps would have suffered from amoebiasis already. It is endemic in our part of the world. and it is the commonest extraintestinal presentation, that is the amoebic liver abscess, and of course the spread is by the fecal oral route. So just if you look at this diagram, it shows the life cycle of ant amoeba. The mature cyst is ingested. ये कैसे इंजेस्ट करते हैं आप? कोई आदमी जिसको MBBS है और उसने अपने हाथ सही तरह से नहीं धोए और उसके जो कुछ उसके हाथों से आपको मिला है, आपने खाया समहाउ दी अदर, वो आपका वेटर हो सकता है, वो आपके घर में काम करने वाला मुलाजिम हो सकता है, वो कोई और हो सकता है जिसने आपकी फूड को हैंडल किया है, और उसके बाद आपने उसको इंजेस्ट करने के बाद व्हेन इट गोज इनसाइड आवर बॉडी, there can be a non-invasive colonization which happens in the cecum, which means the ant amoeba resides there, but it does not form amoebic ulcers, it does not involve the colonic wall mucosa. Once it involves the colonic wall mucosa, then we call it as intestinal disease. It is involving the wall of the intestine. Once there is intestinal disease, it is involving the wall of the colon, then through the blood vessels it would go into the extra intestinal areas like liver, light lung, and even in the brain. While the patient has having a non-invasive colonization, they excrete the ant amoeba in their feces, and that feces contain these things, and through that you can infect other people as well. So if you want to diagnose whether or not your patient is suffering from ant amoeba, invasive colonization or non-invasive colonization, you can do a stool test and you can find these amoeba in these forms under the microscope. Now if we pertain to the today's topic, which is the hepatic amoebic abscess, we know the stages are: it is ingested, it colonizes the colon, it then involves the mucosa, invades, it's causing intestinal disease, and once it is causing intestinal disease, through there it goes into the blood circulation and reaches the liver, lungs, or brain. And this is what it would look like. See here on CT scan, look at this double layer, whereas when we were looking at a simple cyst, it has a simple well circumscribed boundary, but you can see here there is a thickish wall. There are two layers actually, and on ultrasound you can see that there is different echoes which are going. It is multi-echoic. It is not just hyperechoic, anechoic, or hyperechoic. It has multiple, and it has, you can see, granules in them, and even there is some fluid. And when you move the patient, these granules, these debris would move, and that would be a definitive way to diagnose that this patient is having an abscess. Now when we talk about abscess and we aspirate it, this is what we see. This is an anchovy sauce pus. Anchovy sauce. Anchovy is a small sized fish, and its sauce is used actually to eat with steaks. गुरों का भी शौक है एनकवी सॉस पास खाना, एनकवी सॉस खाने का, not pus of course. So confirmatory diagnosis is when you do a stool test and you isolate the parasite from the liver, or you aspirate the abscess through ultrasonic control and you find this kind of pus. And the other is, of course, if you do a colonoscopy and you see ulcers, and through that you take a biopsy, MBBS in the intestinal variety can be diagnosed through that as well. So what can happen if there is a liver abscess in through MBBS? Where can it go? As you can see in this diagram, the complications include, because the size would increase, once the size increases it can rupture, and it can rupture in various areas of the body, like it can rupture into the pericardium, into the lung, into the pleural space, between the diaphragm and the liver, in through the bare area, on the skin when it causes amoebiasis cutis, or into the biliary channels, into the general peritoneal cavity and into the small intestine. So what would decide, how would we know where it is going to perforate? It of course depends upon the size and site of the amoebic liver abscess. Mostly amoebic liver abscess is a single cavity, and more commonly it is on the right side. Why would amoebic liver abscess more commonly be on the right side? What can you think is the reason? The reason is in the anatomy. The right branch of the portal vein is the straighter branch of the main portal vein. When it bifurcates at the level of the porta hepatis, the right is the main channel which continues on the right side, and because the amoebic parasite is coming from the portal vein, so it resides on the right side most of the time, and that is why, depending upon the site of this abscess, it can perforate in all these areas. So it can open into the pericardium, into the lung, into the pleural space, on the skin, from the Bair area, under the diaphragm, into the common bile duct, into the general peritoneal cavity or the small intestine. Now, how do we treat an amoebic liver abscess? So the medical treatment involves giving them metronidazole 400 to 800 milligram 3 times a day for about 10 days, or you can give it injectable 500 milligram IV hourly for 2 weeks, or tinidazole 600 milligram BD for 5 days. And as we know, it is an abscess, there is pus formation, so we need to drain that abscess. That can be done under ultrasound guide, and we have a large bore needle. Under ultrasound you can see the probe over here. He has put the probe, he is guiding the needle to go directly into the abscess cavity, and he is aspirating from the other hand. Now, when do we aspirate? If the size of the abscess is more than 10 centimeter, if the drug therapy is not working and the size is not decreasing, or if there is an abscess in pregnancy and it is not safe for your patient to have flagyl or metronidazole, or the patient has a seronegative abscess. And after ultrasonographic guidance, we can also leave an in situ catheter so that the abscess cavity can be washed subsequently and aspirated. Because larger abscesses, it is not possible usually to empty all of the abscess cavity in a single sitting. Or you can do percutaneous drainage. It can be done by using a pigtail or a Malacot catheter. And if you look at this diagram, this is actually a Nalaton drain. You can put in a Nalaton drain, you can put in a thoracic tube drain, you can put in a Malacot or a pigtail catheter, and sometimes even a Foley catheter. But this is all done under ultrasonographic guidance. And if the abscess cavity is large, or if it has complicated, it has ruptured, then you may have to go in and do an open surgical procedure for those patients. Open or even laparoscopic can be done, but if it has ruptured in the general peritoneal cavity, most of the time you would like to do it through an open procedure, do an open laparotomy. So what are the indications if the above mentioned therapies have failed? And the above mentioned therapies are: one, that we have given antimicrobial, anti-amoebic drugs, we have aspirated it, or even we have placed in a drain under ultrasonographic guidance. If the pus is too thick, it is not being aspirated through the needle, or it does not come through the drain that you have made, or the abscess is multiloculated, or there are multiple abscesses, or the abscess is in the left lobe and it is not possible to assess it through the percutaneous route, or there is a caudate lobe abscess, or the abscess has been ruptured. All these are indications for surgery, and you cannot treat these patients with the methods we have discussed beforehand. Once these patients receive surgery and they have already received metronidazole, you need to give them chloroquine and diloxanide furoate for another couple of weeks to make sure that the disease is completely eradicated. Then the other kind of abscess that you can have in liver is a pyogenic liver abscesses. Amoebic liver abscesses जो पुराना ट्रेडिशनल तरीका है, जो एनेक्डोटल है, उसमें कहते हैं कि अगर आपने एक एब्सेस है लिवर में राइट साइड पे है तो अमेबिक है, अगर मल्टीपल हैं दोनों लोब्स में है तो उनके पायोजेनिक होने का इम्कान बहुत ज़्यादा है. Now how would these organisms that are listed here would reach into the liver to cause pyogenic liver disease? Now एक रास्ता है डायरेक्ट इनोकुलेशन, कोई स्टैब हुआ है, कोई ऐसी इंजरी हुई है पेनिट्रेटिंग जिसकी वजह से वो ऑर्गेनिज्म दाखिल हो गया. दूसरा थ्रू दी हेपेटिक आर्टरी, तीसरा थ्रू दी पोर्टल वेन, चौथा थ्रू दी कॉमन बाइल डक्ट जो असेंडिंग कोलिंजाइटिस के ज़रिए है, और पांचवा डायरेक्टली थ्रू दी लंग से आ सकता है, डायफ्राम से ट्रांस डायफ्रैग्मेटिक होके आ सकता है. सो दीज आर दी ways through which these causative organisms can reach into the liver and cause pyogenic liver disease. Most of the times it is because of biliary stone disease. Why? When the biliary stone goes into the common bile duct and obstructs the flow of the bile. Remember, where there is stagnation, जहाँ पे भी रुकावट होगी, जहाँ पे भी accumulation होगी फ्लूइड की, वहाँ पे इन्फेक्शन होने का इम्कान बहुत ज़्यादा. सो biliary stone disease leads to ascending cholangitis leads to pyogenic liver disease. Then appendicitis, then diverticular disease. These are the infective conditions most of the time caused by E. coli, and that through portal pyemia reaches the liver and causes pyogenic liver disease. Now सब लोगों में क्यों नहीं होता ये देखिए. अगर आप इन लोगों में देखें, एल्डरली, डायबिटिक्स, एक्चुअली दीज आर ऑल इम्यून कॉम्प्रोमाइज पेशेंट्स. नॉर्मली जो छोटे मोटे इन्फेक्शंस होते हैं जो लिवर तक पहुंचते हैं, लिवर इज़ एबल टू डील विद देम प्रॉपरली, बट पीपल हु आर इम्यून कॉम्प्रोमाइज, स्पेशली इन डायबिटीज़ एंड एल्डरली पॉपुलेशन, दे वुड डेवलप पायोजेनिक लिवर डिजीज. So how do we confirm? The confirmation is through imaging. It can be done by an ultrasound, it can be done by a CT scan, and if you look at this CT scan, this is a telltale sign. This is an air fluid level. There is this air and there is this fluid and there is this straight line. Once again there is another air fluid level here. So you can aspirate this under imaging, and that aspirate then can be cultured and you can have a sensitivity and you can start antibiotics according to that sensitivity. What can happen once again? Once again, these abscesses can also rupture into the general peritoneal cavity, into a vessel, and they can cause sepsis. Because of their size, because of their infection, the liver may not be able to perform its function. As we know, the various functions of the liver can cause liver failure. They can also rupture into the pleural cavity. This chest X-ray here is of an amoebic liver abscess which has burst into the right-sided pleural space. Now what would we do for this patient? अगर ये पेशेंट है जिसके amoebic liver abscess जो है रप्चर होगी राइट प्लूरल स्पेस में, इस पेशेंट को आप लोग कैसे ट्रीट करेंगे? What would you do? The treatment would be the same. We need to drain this pus. We need to take out this pus from the body. So we would need in addition to other things, we would need to put in a thoracic tube drain to these patients as well. Now treatment once again for pyogenic liver disease resembles the treatment for amoebic liver abscess. These patients would require antibiotics and once again ultrasonographic guided aspiration or percutaneous drainage. The antibiotics we use, as we have seen, the causative organisms are most of the times gram negative or they are anaerobes. So you need gram negative and anaerobic cover. For that you can give penicillins with aminoglycosides and metronidazole or third generation cephalosporins with metronidazole. Sometimes we require to do open surgery for pyogenic liver disease as well. When we would have to do it? When once again either there is a rupture, there is recurrence of the disease, the size is too large, the pus is too thick and it cannot be drained percutaneously. Then you'll have to go in either laparoscopically or through an open method to treat this abscess by drainage. Then once again, it is a very common disease in Pakistan, the hydrated liver disease. It is caused by another organism which is known as Echinococcus granulosus. There are 2 or 3 other varieties of Echinococcus as well, but which also can cause hydrated disease, but the most common variety is the Echinococcus granulosus. It is also known as dog tapeworm. Now it has 3 layers. There is a pericyst, which is derived from the host tissue. It is the inflammatory response of the host tissue which causes the formation of this pericyst. Then there is an ectocyst, the outer covering or the capsule of the cyst, which is hyaline, and remember, it is non-infective, and an endocyst, which has a living germinal membrane with viable parasites inside. So once we have decided to operate on these patients, we work between the pericyst and the ectocyst so that the germinal membrane is not damaged, it is not opened, and the viable parasites do not seed themselves into the general peritoneal cavity. तो एक दफ़ा अगर आप सर्जरी करने का फैसला करते हैं तो आप इस प्लेन को ढूंढने की कोशिश करते हैं between the pericyst and the ectocyst. Once again, we know the life cycle, we know human beings and sheep are the intermediate hosts, and dog is the definitive host, and human beings are infected when there is the embryonic egg in the feces. Once again, the infection route is the fecal oral route, and after ingestion, what happens? It goes into the intestine. After going into the intestine, where it develops into further stages and it reaches the liver. But it is not the only space where a hydrated cyst can take place. A hydrated cyst can be present in liver, it can be present in the pericardial sac, it can be present in the lungs, in the brains, and even in the general peritoneal cavity. So even in bones as well. So it's not just the hydrated disease is not just limited to liver. Though it comes from the intestine, it comes from the fecal oral route, but once it reaches the general circulation, if it goes into the portal circulation, it goes into the liver. But if it goes into the general circulation, it can go to the rest of the parts of the body that we have already talked about. So the WHO classification is based on ultrasound findings. Group 1 is a cyst which is active, it is more than 2 centimeter in size and is fertile. Fertile means that it has live daughter cysts in it, and if the cyst would rupture, there would be multiple new cysts formed. Group 2 are the transition cysts, in which it has started to degenerate, and group 3 is the inactive, the degenerated or the partially or totally calcified cyst. So if on imaging you find that a cyst's wall is calcified, so it means that it is already inactive. So you would ask, if it is an inactive cyst, why do we need to treat it? Now the reason for treating an inactive cyst would rest on its once again site and size, because that is the determinant कि जो पेशेंट को जो सिम्टम्स हो रहे हैं वो डिपेंड करते हैं कि वो कहाँ पे पड़ी है और उसका साइज़ क्या वो बिलरी डक्ट की ऑब्स्ट्रक्शन कर रही है, क्या वो किसी ऐसी जगह पड़ी है जहाँ पे उसका रप्चर ना होने के बावजूद उसका साइज़ आ जाए तो पेशेंट को पेन हो रही है. सो if it is calcified, you only treat when it is symptomatic, whereas if it is fertile, the reason to treat is that it may not rupture and cause sepsis to the patient. Most of the times it is asymptomatic and it is discovered incidentally. आपने किसी और चीज़ के लिए इमेजिंग कराई है, अल्ट्रासाउंड कराया है, सीटी कराया है, और उसमें आइडेंटिफाई हो गया कि पेशेंट को तो हाइड्रेटेड सिस्ट भी है. मोस्ट कॉमन प्रेजेंटेशन इसकी डल एक है राइट अपर क्वाड्रेंट में विद और विदाउट वॉमिटिंग. वॉमिटिंग यूजुअली उस वक्त होती है जब ये गैस्ट्रिक आउटलेट को ऑब्स्ट्रक्ट कर रहा होता है बिकॉज ऑफ इट्स साइज. Then it can cause shortness of breath if there is pleural effusion subsequent to a cyst in the liver, or it can cause jaundice if it is obstructing the biliary outflow, and sometimes if the cyst has ruptured into the general peritoneal cavity, the patient may present with an anaphylactic shock. Then how do we investigate? On complete blood count, these patients have a raised eosinophilic count. the total eosinophilic count would be raised. Then we can do ELISA and immunoelectrophoresis to identify the antibodies against Echinococcus granulosus. Ultrasound, of course, imaging, and CT scan is said to be the modality of choice. MRI is, because it's not now so much at this point of time, not as much freely available as a CTs, so CT still remains a modality of choice for hydrated liver disease, and it shows a smooth space occupying lesion with several septa, which is known as a cartwheel sign. And then let's have a look at the image. Look at this, how beautiful does it look. It's a hydrated cyst. Why do I say it's a hydrated cyst? It is because of this hyaline like membrane lying within the cyst, and this sign is known as a water lily sign. Just like a water lily looks like this hyaline membrane, the live fertile parasite lying inside the cyst is water lily. Or it can be multiple. It can be a large cyst with multiple small cysts inside. See the wall, you can see there is some calcification of the wall. There is some. It is in stage 2 of the WHO classification. It is a transition, but the important thing is that the daughter cysts lying inside, the daughterless cyst lying inside, and these floating membranes inside the daughter cyst tell us that though the large mother cyst may be dying, or it's in a degenerative state, but the daughter cysts are very much alive and they are fertile. And if you look at the size, see the whole of the right lobe of the liver is gone. It's replaced by this huge hydrated cyst, and it would definitely be causing obstruction to the biliary outflow as well. Then these cysts can be lying in the general peritoneal cavity as well. You can see they're lying in the general peritoneal cavity, or this cyst can be in the brain as well. The whole of the right parietal lobe is replaced by this huge huge hydrated cyst, which is shifting the midline to the opposite side and causing contraction and of the ventricle as well. Now, how do we treat? The treatment, main indication is to prevent the progressive enlargement and subsequent rupture of the cyst, because we've already talked about that once the cysts rupture, ये जो फर्टाइल सिस्ट चले जाएंगे, ये सीडलिंग चले जाएंगे, जहाँ जहाँ एक छोटे से छोटा माइक्रोस्कोपिक इसका ज़र्रा भी जाएगा, वहाँ एक फुल फ्लैज्ड नई सिस्ट बन जाएगी. सो व्हाट डू वी स्टार्ट विद दिस albendazole 400 milligram BD for 4 weeks cycle with 2 weeks free interval. तो यूजली 3 से 4 साइकिल इस्तेमाल करते हैं, ठीक है. और praziquantel और mebendazole can be used. All these 3 drugs can be used separately and sometimes even in combination as well. Or you can do what is known as a pair technique instead of operating, because we know कि जब हम ऑपरेशन करते हैं उसमें सीडलिंग होने का, especially if there is live fertile cyst, daughter cyst present, it can happen. तो उसमें हम कोशिश ये करते हैं कि ऐसी टेक्निक इस्तेमाल करें जिसमें सेप्सिस होने का, सिस्ट इनोकुलेशन होने का इम्कान कम से कम. तो उसके लिए हम जो करते हैं उसको कहते हैं पेयर, पंक्चर, एस्पिरेशन, इंजेक्शन एंड री एस्पिरेशन. सबसे पहले हम पेशेंट को एक इनिशियल कोर्स देते हैं एल्बेंडाजोल का. वो कितनी देर के लिए था? फॉर 4 वीक्स. 4 वीक्स का कोर्स देने के बाद हम फिर इमेज गाइडेड पंक्चर करते हैं. इमेज गाइडेड का मतलब यहाँ पे आप अल्ट्रासाउंड समझिए. अल्ट्रासाउंड में हम सिस्ट को पंक्चर करते हैं, सिस्ट के कंटेंट्स को एस्पिरेट करते हैं. क्या मकसद है इसका? उसको एस्पिरेट करने का सबसे बड़ा मकसद ये कि सिस्ट को थोड़ा सा आप खाली करेंगे तो फिर उसके अंदर आप इंजेक्ट कर सकते हैं जो स्कोलिसिडल आपने सोल्यूशन डालना. देन यू इंस्टिल अ स्कोलिसिडल सोल्यूशन. ये जो सारी चीज़ें जिनका नाम लिखा है, ये सब जो स्कोलिसीज हैं, जो बच्चे सिस्ट है उनको मार सकती है. हाइपरटोनिक सोलाइन 15 to 20% कंसनट्रेशन में, एथनॉल 75 to 95% और पायोडीन 1%. ऑल ऑफ दीज आर स्कोलिसिडल. दिस विड किल दी डॉटर सिस्ट. जब हम सर्जरी करते हैं उसमें भी मतलब ट्रेडिशनली हम यही करते हैं कि हम डार्क कलर्ड स्पंजेस यूज़ करते हैं किसी सफ़ेद कलर की बजाय. और जब हम सिस्ट को खोलने से पहले अच्छी तरह से लिवर को चारों तरफ से पैक कर लेते हैं all sponges that we used are soaked in a scolecidal solution, जो most commonly is hypertonic saline. जब when we were in training during my house, जब हम लोग formalin इस्तेमाल करते थे, and that was a real, हर सर्जन की आंख से आंसू निकल रहा होता था, सुड़ कर रहे होते थे, लेकिन साथ सर्जरी होती थी. तो अब फॉर्मलिन इस्तेमाल नहीं की जाती, हाइपरटोनिक सेलाइन को यूज़ करते हैं, एथनॉल या पायोडीन सोल्यूशन को यूज़ करते हैं. तो सारे स्पंज से अच्छी तरह कवर कर लेते हैं, फिर उसको इंस्टिल करते हैं, सारा जो स्कोलिसिडल सोल्यूशन फैला देते हैं, ताकि जब आप खोलें सिस्ट को, और खोलते ही आपकी कोशिश होती है एस्पिरेट करके सारा शक्कर के अंदर आ जाए, और अगर कोई खुदा न खास्ता स्कोलिसिस निकल भी जाए तो वो इस स्कोलिसिडल सोल्यूशन में की वजह से डेथ हो. ये ओपन सर्जरी की बात है. मगर पेयर में हम पहले एल्बेंडाजोल देने के बाद हम सिस्ट को पंक्चर करते हैं, इमेज गाइडेड एस्पिरेट करते हैं, उसमें ये इंस्टिल करते हैं, और उसके बाद फिर उसको री एस्पिरेट करते हैं. सर्जरी कब करते हैं? सर्जरी उस वक्त करते हैं, वंस अगेन इट डिपेंड्स अपॉन द लोकेशन एंड नंबर ऑफ सिस्ट. तो क्या क्या किया जा सकता है? एक तो हम रेडिकल टोटल सिस्ट की पूरी एक्सचेंज करते हैं, और हम कहाँ करते हैं? हमने एक्टोसिस्ट, जो कि जो होस्ट टिश्यू का रिएक्शनरी लेयर है इन्फ्लेमेटरी, उसके और एंडोसिस्ट के दरमियान आप प्लेन बना के पूरी सिस्ट को निकालते हैं, या हम सिस्ट को खोल देते हैं, उसकी रूफ को खोल के उसको इवैक्यूएट करके उसकी हाइलाइन मेम्ब्रेन को निकाल के ओमेंटोप्लास्टी कर देते हैं, उसको प्लग कर देते हैं, ओमेंटम को उसके अंदर रख देते हैं. ठीक है. या हम अगर जैसे हमने पिछली इमेजिंग में देखा था कि पूरी राइट लोब जो है वो रिप्लेस हो गई है विद अ ह्यूज हाइड्रेटेड सिस्ट, देन वी मे हैव टू टेक अवे द होल ऑफ द हेपेटिक सेगमेंट विच इज इन्वॉल्विंग दैट सिस्ट. आई हैव नॉट इंक्लूडेड, मैंने इसमें कोई ऑपरेटिव प्रोसीजर की या पेयर की तस्वीरें उस तरह नहीं रखी हैं, और ये आपकी असाइनमेंट होगी. मैं कोशिश करूँगा कि मैं आपको यूट्यूब के लिंक्स ढूंढ दूँ, नहीं तो आपने खुद पेयर का और ऑपरेटिव प्रोसीजर हाइड्रेटेड सिस्ट को यूट्यूब पे देखना है, और फिर जो असाइनमेंट में सवाल हैं उनके जवाब देना. देन अ वेरी ब्रीफ वर्ड अबाउट वास्कुलर लीजन. द मोस्ट कॉमन वास्कुलर लीजन इन लिवर इज अ hemangioma. It is a benign tumor in which there is it is once again congenital, it is commoner in females, and it usually is solitary. So for a solitary benign hemangioma of liver, what do we need to do? We usually do not need to do anything. Only once it becomes symptomatic. और symptomatic कब होता है? Once again it depends upon its size and its site. If it becomes symptomatic and it may compress the gastroduodenum to cause outflow obstruction, vomiting कर रहा है, या biliary channel को किसी को obstruct कर रहा है, उस सूरत में फिर हम इसके बारे में ट्रीटमेंट के बारे में सोचते हैं. क्या क्या कर सकते हैं आप? हेमेंजियोमा चूँकि एक ब्लड फिल्ड benign ट्यूमर है, तो हम क्या कर सकते हैं? We can do what is known as a embolization. We can do an arterial embolization. So you can see, अगर ये एक पोस्टमार्टल लिवर की तस्वीर है जिसमें ये हेमेंजियोमा है, बिल्कुल पेरिफेरी में पड़ा है, इसका साइज़ छोटा है, इसका इम्कान कि ये प्रेशर की वजह से, साइज़ की वजह से किसी चीज़ को ऑब्स्ट्रक्ट कर रहा होगा या सिम्टमेटिक होगा, होने का इम्कान बहुत कम है. तो इस किस्म के हेमेंजियो में जो इंसिडेंटल फाइंडिंग्स होते हैं इमेजिंग पे, यूजली वी डू नॉट नीड टू डू एनीथिंग फॉर देम. यू ओनली ट्रीट देम वंस दे बिकम सिम्टमेटिक. सो बच्चों में आमतौर पे दे आर मल्टीफोकल, समटाइम्स दे मे इन्वॉल्व अदर ऑर्गन्स एज वेल. जो बड़े साइज़ के हेमेंजियोमास होते हैं वो AV शंटिंग कर सकते हैं. दैट कैन लीड टू कंजेस्टिव कार्डियक फेलियर एंड दैट मे सब्सिक्वेंटली बी द रीज़न फॉर ट्रीटिंग दोज हेमेंजियोमास. Now the complications, of course, once again they can cause rupture, they can be disseminated intravascular coagulation or thrombocytopenia. The confirmation is done by an MRI or a triple contrast or a triphasic CT scan, जिसकी हमने उस दिन बात की थी, ट्राइफेजिक CT स्कैन. और ट्राइफेजिक की 3 फेजेस क्या होती हैं? आर्टीरियल फेज होती है, वॉश आउट फेज होती है और पोर्टल वीनस फेज होती है. ट्रीटमेंट ऑप्शंस हमारे पास क्या हैं? बिकॉज इट इज़ अ हीमेंजियोमा वी कैन डू एम्बोलाइजेशन. हम इन्वेजिव रेडियोलॉजी के ज़रिए हम कैथेटराइज करते हैं हेपेटिक आर्टरी को, आइडेंटिफाई करते हैं कि फीडिंग वेसल कौन सी है और उसको एम्बोलाइज कर देते हैं, कॉइल डाल देते हैं, फोम डाल देते हैं, जिसकी वजह से ब्लड सप्लाई ख़त्म हो जाती है और हीमेंजियोमा की ब्लड सप्लाई ख़त्म हो जाती है, हीमेंजियोमा बाद में खुद ही ख़त्म हो जाती है. या रेडियोथेरेपी कर सकते हैं, और या अगर ये आपके पास दोनों फैसिलिटीज़ अवेलेबल नहीं है या पॉसिबल नहीं है तो देन यू डू अ सर्जिकल रिसेक्शन. दिस इज़ व्हाट अ हीमेंजियोमा लुक्स लाइक ऑन एन अल्ट्रासाउंड. कैन यू टेल मी, वी डिस्कस्ड दिस काइंड ऑफ इमेज. हमने कहा था अल्ट्रासाउंड में जो इस किस्म का इमेज होता है वो कैसा होता है, वो किस चीज़ की वजह से होता है, ये किस चीज़ की कंसिस्टेंसी से मिलता है और इसको हम क्या कहते हैं. ठीक है, तो दिस इज़ योर सेकंड असाइनमेंट. पहली असाइनमेंट क्या है? आपने यूट्यूब से पेयर देखना है और आपने हाइड्रेटेड सिस्ट की सर्जिकल ट्रीटमेंट देखनी है, उसके बारे में एक सवाल होगा. और दूसरा सवाल ये है कि ये जो हीमेंजियोमा नज़र आ रहा है इसको हम अल्ट्रासाउंड पे क्या कहते हैं, ये किस किस्म का है, ये हाइपर एक्वोइक है, ये हाइपो एक्वोइक है, ये एनएक्वोइक है, और इसकी कंसिस्टेंसी किस चीज़ से रिजेंबल करती है. देन हीमेंजियोमा हमने कहा था जो इन्वेस्टिगेशन ऑफ चॉइस है वो ग्लैडियोलोनम जो हम देते हैं, ग्लैडियोलोनम दे देते हैं एज अ कंट्रास्ट, और उसके बाद आप एमआरआई करते हैं. एंड यू कैन सी कि कितनी अच्छी इन्हांसमेंट है. ये अभी कंट्रास्ट यहाँ पहुँचा नहीं है, ये कंट्रास्ट पहुँचना शुरू हो गया, और ये अभी आर्टीरियल वेसल्स के अंदर है, और ये वंस द कंट्रास्ट हैज़ कम्प्लीटली आउटलाइन द होल ऑफ द हीमेंजियोमा. यू कैन सी ये आर्टरीज भी इसमें नज़र आ रही हैं और पूरा हीमेंजियोमा इसमें नज़र आ रहा है. सो दिस इज़ द GD-MRI इज़ द इन्वेस्टिगेशन ऑफ चॉइस टू डायग्नोज अ हीमेंजियोमा. और आप देख सकते हैं दिस इज़ नोन एज प्रोग्रेसिव सेंट्रीपीटल एनहांसमेंट. सेंट्रीपीटल नॉट सेंट्रीफ्यूगल. ये एजेस से सेंटर की तरफ आता है, एजेस से सेंटर की तरफ आता है. So if there are questions, any questions, you can post them on the Google Classroom comment section, or you can directly email any questions that you have, and I would be very happy to answer all of them. Thank you very much.